Okay, let's unpack this. Imagine you are a medical student on rotation, or maybe a junior emergency doctor just starting out. A patient rolls in feeling a bit lightheaded, maybe just tired. You get the ECG leads on, and there it is. That squiggly line, it holds so many secrets about what's happening inside their heart. Today, we're doing a deep dive into some of those critical secrets, the nuances of cardiac conduction abnormalities. Specifically, we're talking atrioventricular blocks, from first degree all the way to complete block, and also the fascinating world of fascicular blocks. This deep dive is really tailor-made for you, whether you're prepping for exams or honing your diagnostic skills in the ED.
Exactly. And our sources today are, well, they're the foundational texts and clinical guidelines that frontline doctors like you rely on. We'll be pulling out the crucial nuggets of knowledge, the things that will help you quickly understand what you're seeing on that ECG. And maybe more importantly, what it actually means for your patient. It's really quite fascinating how seemingly small changes in the heart's electrical rhythm can have profound clinical implications, especially when we talk about patient stability.
Right. So our mission here, it's to equip you with those aha moments. Those moments you need to confidently interpret these often tricky ECGs and, crucially, understand the immediate clinical relevance. We're talking the what, the why it matters, and maybe most importantly, the what to do next for these specific heart blocks. Okay, so to really appreciate these blocks, maybe we should first do a quick refresher on the heart's electrical superhighway. Remember those key players?
Absolutely. Yeah, quick review is always good. So we start at the sinoatrial node, the SA node. That's the heart's natural pacemaker that generates impulses that spread through the atria. Then they all converge at the atrioventricular node, the AV node. And this node introduces a critical delay. It's really important. From there, the impulses travel down the bundle of His, which then splits into the left and right bundle branches.
And the left branch splits again, right?
That's right. The left branch further divides into the left anterior fascicle and the left posterior fascicle. Finally, it's the Purkinje fibers that spread the signal out to ensure coordinated ventricular contraction. So disruptions at, well, any of these points can lead to different types of heart block.
Got it. So we've got our electrical map laid out. Let's zone in on the atrioventricular blocks first, the AV blocks. What's the core concept we really need to grasp here? What ties these different degrees of block together?
Well, at its heart, AV block means that the atrial depolarization, the signal from the top chambers, fails to reach the ventricles properly. Now, this failure can happen at the AV node itself, or it can happen lower down in that His-Purkinje system we just talked about. And here's a really key differentiating factor for you to spot on the ECG, the QRS complex width.
Ah, the QRS width. That's important, isn't it?
Hugely important. If the block is at the AV nodal level, so higher up, the QRS complexes will generally be narrow. But if the block is lower down in the His-Purkinje system, the QRS complexes tend to be wide. And crucially, this is a big clinical point. The higher the block, the more likely it is to respond to therapies that increase sympathetic tone, like atropine.
Okay, so narrow QRS often means nodal block, possibly responsive to atropine. Wide QRS suggests a lower block, less likely to respond. That's a great pearl. All right, first up, first degree AV block. What does this look like on the ECG? And honestly, how worried should we be?
Right. So on the ECG, what you'll see is a constant prolongation of the PR interval. That's defined as being greater than 200 milliseconds, or one big square on the ECG paper. But importantly, every P wave is followed by a QRS complex, and the QRS itself stays narrow. While it can be an early sign of maybe fibrosis or ischemia in the AV node, it's most commonly just a normal variant, often completely asymptomatic.
So often an incidental finding, though?
Very often, yeah. In the context of, say, an acute coronary syndrome, you definitely monitor it for progression, just in case. But generally, it doesn't require immediate treatment on its own. It's usually something you just need to recognize and note down.
Okay, makes sense. Let's move on to second-degree AV block. First, the famous Wenckebach or Mobitz type I. This is where it gets a bit more dynamic with that progressive lengthening.
Precisely. With Wenckebach, the PR interval progressively lengthens with each successive beat. Longer, 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 until eventually a P wave occurs that is not conducted, meaning there's no QRS following it. You get a dropped beat. This is actually quite common, especially, for example, after an inferior acute myocardial infarction.
Okay, so you see it after an inferior MI sometimes. Does it often cause problems?
Well, it could progress to complete heart block, but it's normally asymptomatic
Yeah.
and generally resolves on its own without needing urgent intervention. You'll want to monitor the patient, of course, keep an eye on them. But our sources emphasize it's normally asymptomatic and resolves without the need for urgent intervention. So don't panic immediately.
Right, monitor, but don't necessarily jump to intervene.
Got it. And how about the other type of second-degree block, Mobitz type 2? This one has a bit more of a, well, notorious reputation, doesn't it? It certainly does. Yeah, Mobitz 2 is different. Unlike type I, Mobitz type 2 shows a constant PR interval. The conductive beats all have the same PR length. But then suddenly, some P waves simply fail to conduct to the ventricles. You just get a P wave with no QRS after it. You might see fixed ratios, like a 2.1 block where every other P wave is blocked, or maybe a 3.1 block.
And this one is more concerning.
Much more concerning, yes. It's less common than Mobitz type I, but it's often symptomatic. Critically, it suggests pathology lower down, often septal involvement, especially if you see it during an acute MI. And this type commonly progresses to complete heart block. It's much more unstable. This is the kind of block where patients diagnosed preoperatively often get pacemakers prophylactically. The key takeaway, especially for you in the ED, is that it commonly progresses to complete heart block, which may require urgent intervention. This one is a bigger deal.
Okay, constant PR interval with dropped beats. Think Mobitz 2, think higher risk, think potential pacing. Right, that brings us to the final AV block, third degree or complete heart block. What's the hallmark here, and why is it so critical?
This is where you see complete AV dissociation. The atria and the ventricles are electrically disconnected. They're doing their own thing. The P waves march along at their own atrial rate, and the QRS complexes march along at their own slower ventricular escape rhythm rate. There's absolutely no relationship between the P waves and the QRS complexes.
And that escape rhythm, it can be quite slow, can't it?
It can be dangerously slow. If that escape rhythm originates higher up, maybe near the AV junction or high septum, it might be around 40-50 beats per minute, which is often still symptomatic.
Right.
But if it's originating from lower down in the ventricles, it can be really slow, like 30-40 beats per minute, sometimes even slower. And those QRS complexes will usually be wide because the impulse isn't using the normal conduction pathways.
And clinically, what does this usually mean for the patient?
Clinically, while it can occasionally be an incidental finding in, say, a very fit athlete with high vagal tone, it usually presents with significant symptoms. We're talking lethargy, dizziness, presyncope, syncope. It often indicates severe underlying disease like fibrosis or ischemia affecting the conduction system significantly. This absolutely requires a permanent pacemaker, there's no question. And another important point, especially relevant if you're dealing with an acute anterior MI, complete heart block in the setting of acute anterior MI indicates extensive septal damage and is a poor prognostic sign. It suggests a much worse outcome.
Okay, complete dissociation, slow escape rhythm, often wide QRS, usually symptomatic, needs a pacemaker. Got it. Now let's shift gears slightly. We've covered blocks primarily at or near the AV node. What about problems further down that pathway? Let's talk about fascicular blocks.
Right. Good transition. So now we're moving below the AV node into the His-Purkinje system itself. Bifascicular block is defined as a conduction defect affecting two of the three main fascicles down there. Remember, the bundle of His splits into the right bundle branch and the left bundle branch. And that left bundle branch then divides again into the left anterior fascicle and the left posterior fascicle. So we're talking about problems involving the right bundle branch plus one of the left fascicles, or sometimes both left fascicles. So that's less common to discuss as bifascicular. Usually it's RBBB plus one left fascicle.
Okay, so a block in two out of those three pathways, right bundle, left anterior fascicle, left posterior fascicle. What are the common patterns we'll actually see on the ECG for bifascicular block? How do we spot them?
Okay, there are two main patterns you need to recognize. The most common by far is right bundle branch block, RBBB, combined with left anterior fascicular block, LAFB. So first you'll see the signs of RDBB, a widened QRS, usually that sort of RSR pattern, sometimes called rabbit ears in leads V1, maybe V2 or V3, and often slurred S waves over in V5 and V6. But the crucial addition here is left axis deviation, or LAD.
Left axis deviation, how do we spot that easily?
You look at leads I and AVF. With LAD, lead I will be positive pointing up and lead AVF will be negative pointing down. You'll also typically see small Q waves and tall R waves in leads I and AVL, and small R waves with deep S waves down in leads 2, 3, and AVF. So RBBB pattern plus that left axis deviation equals RBBB with LAFB.
Okay, RBBB plus LAD equals BBB LAFB. What's the other pattern?
The second, much rarer pattern is right bundle branch block, RBBB, combined with left posterior fascicular block, LPFB. Again, you'll see the typical RBBB pattern wide QRS, maybe the RSR in V1. But this time, instead of left axis deviation, you'll see right axis deviation, or ERDE. For ERDI, lead eye will be negative pointing down and lead AVF will be positive pointing up. You'll see small R waves with deep S waves in I and AVL and small Q waves with tall R waves in 3 and AVF.
So RBBB plus RA equals RBBB LPFB.
Exactly. And here's a key rule to remember straight from our sources. As a rule, RBBB by itself usually has a normal axis on ECG. Whenever RBBB occurs with axis deviation either left or right, LAFB or LPFB should be looked for to diagnose bifascicular block.
That's a great clinical shortcut. If you see RBBB, always check the axis. If it's deviated, think bifascicular block. So how do these patterns actually impact our patients? Are they always a problem? What should we do about them?
Well, often, just like first-degree AV block, bifascicular block can be asymptomatic and just an incidental finding on an ECG. The patient might feel totally fine. However, it can progress to complete heart block, or maybe intermittent complete heart block. And that's when it manifests with symptoms like presyncope, syncope, shortness of breath, or maybe just weakness on exertion.
Is that progression common?
The rate is generally low, actually,
Mm-hmm.
about 1% per year in patients who are asymptomatic. But it's significantly higher, maybe up to 17% per year, in individuals who are symptomatic, especially if they also have a prolonged PR interval, like a first-degree AV block on top of the bifascicular block.
Ah, so symptoms or that added first-degree block are warning signs for faster progression.
Definitely. And here's a critical red flag, particularly for the emergency setting. Chest pain with a new bifascicular block on ECG suggests acute myocardial infarction due to proximal LAD occlusion. The left anterior descending artery often supplies the septum where these bundles run. So even if there's no obvious ST elevation yet, these patients need urgent admission, cardiac monitoring, a cardiology consult, AACP, serial cardiac markers, and an echo. It's a big deal. Wow, okay. New bifascicular block plus chest pain equals potential LAD occlusion. That's vital. What about management for asymptomatic versus symptomatic patients without acute chest pain?
Right. For asymptomatic patients, once you've ruled out reversible causes like electrolyte abnormalities, they usually don't need immediate intervention. They can often be discharged with safety netting advice and arranged outpatient follow-up. However, symptomatic patients, particularly those with syncope or presyncope, absolutely should be admitted, usually under cardiology. Those symptoms strongly suggest they might be having intermittent complete heart block.
And what happens once they're admitted? They'll need evaluation for a permanent pacemaker. This often involves electrophysiological studies, or EPS, to really test the conduction system's integrity. A pacemaker is generally indicated if they're found to have intermittent third-degree block, or if they have Mobitz type 2 second-degree AV block, along with a bifascicular block, or something called alternating bundle branch block. Or interestingly, if they have certain neuromuscular diseases that are known to affect conduction, they might get a pacemaker even without symptoms.
Okay. And you mentioned atropine earlier for AV nodal blocks. What about for these lower blocks if they progress?
Yes, very important distinction. This is vital for your practice. Unlike AV nodal blocks, atropine will not work for those patients who progress to episodes of trifascicular block, meaning complete heart block in the context of bifascicular block, within the emergency department. Remember, the block is below the AV node, where atropine primarily acts. These patients will require pacing, often urgently, either transcutaneous pacing initially or transvenous pacing.
Right. Atropine is unlikely to help with complete block when there's underlying bifascicular block. Pacing is the key. You mentioned trifascicular block there. That term sometimes causes a bit of, well, head scratching. Can you clarify what it actually means?
Yeah, it certainly can be confusing. Historically, the term trifascicular block was sometimes used, perhaps a bit loosely, whenever you saw bifascicular block along with any degree of AV block, first, second, or third. But technically, first and second degree AV blocks are usually due to pathology at the AV node, not necessarily a problem in the third fascicle itself. So calling that trifascicular is arguably a bit of a misnomer.
So what's the more precise definition?
A true trifascicular block really implies pathology affecting all three fascicles. So the most accurate use of the term is when you have a bifascicular pattern on the ECG plus a complete third-degree heart block. That truly indicates that conduction down all three pathways is disrupted. Clinically, though, you'll still hear people use the term incomplete trifascicular block to describe bifascicular block with a first or maybe second-degree AV block and complete trifascicular block for bifascicular block with third-degree AV block. It's just good to be aware of the slight nuance in terminology.
That clarification is really helpful. Understanding the terminology helps us communicate effectively. Wow, what an incredibly detailed and really practical deep dive into AV and fascicular blocks.
Mm.
We've gone from the subtle prolongation of a PR interval in first-degree block all the way to that complete electrical chaos of third-degree block. And we learned how spotting axis deviation with a bundle branch block can immediately point you towards a fascicular issue.
Absolutely. And I think the key message, the big takeaway for you listening is always correlate your ECG findings with the patient's actual clinical picture. Are they symptomatic? What are their vital signs? Understanding the likely location of the block, is it likely AV nodal or further down in the His-Purkinje system? That's what really guides your immediate management, especially when thinking about things like the potential effectiveness of atropine versus the definite need for pacing.
Right. So as you step into your next shift, or as you're preparing for that next exam, try to remember these distinct patterns and, more importantly, their implications. They really aren't just lines on a piece of paper. They tell a crucial story about the heart's electrical integrity. And understanding that story means you're better equipped to be that sharp, well-informed clinician. So maybe a final thought to leave you with. How might missing one of these subtle ECG changes, like a new bifascicular block in someone with chest pain, or misinterpreting a Mobitz 2 as a Mobitz 1st, fundamentally change a patient's entire trajectory, especially in that fast-paced ED environment? Something to definitely keep in mind.